we now need to go to the next session, which is the next line of healing, physical and occupational therapy at the heart of patient-centered care for people with disabilities. The moderator is one of our very own, Mona. Mona Arsenault is the chair of Polio Quebec and a leading Canadian advocate for polio survivors and post-polio syndrome awareness. A survivor herself, she works to strengthen support networks, improve access to accurate information, and ensure survivor needs are recognized in Canada's health systems. Her leadership brings clarity, compassion, and a powerful voice for dignity and inclusion. Welcome, Mona and panel.
Hello, everyone. I'm Mona Arsenault, and thank you for that wonderful introduction. I'm the moderator this morning on the physiotherapy and occupational therapy treatments. The difference between you and me is you see my disability, but I don't always see the public's. Now I call myself an adventurist because being courageous and inspirational is not something I feel I have the right to be. And now our professionals. Today we will introduce Dr. Maria de Mello from Brazil, the Chief Scientific Officer, English occupational therapist who has a postdoctorate works at University of Florida in the United States since 2006. She has her PhD in sciences from the Federal University of São Paulo, Brazil, since 1999. She is the Executive Director, Founder, Technical Mobility Inclusion from Brazil since 2014. She is the Senior Researcher and Innovative Leader, AME, Association of Friends of Exceptional Metro Workers, 2024 to the present. Leadership in accessibility, innovation, user-centered design, process optimization, and collaboration with multidisciplinary teams. We will also meet Tatiana Silva from Brazil, the physical therapist, a PT and PhD, proprietor of the Clinica RNA, and she holds her degree in physical therapy. That's PT and PhD. She is a specialist in aquatic physiotherapy for neuromuscular diseases, a specialist in integrative care. She has her master's in neuroscience and is a director of the Brazil Association of ALS, director of the G14 Association for Post-Polio Syndrome Patients. She is also the proprietor of Clinica RNA, Neurological and Aquatic Rehabilitation Clinic in São Paulo, Brazil. With more than 25 years of post-polio syndrome multi-care experience, I'd like to welcome them.
Hello to everyone. It's a pleasure to be here today. And I'm so sorry because my camera is not working. I would love to have you seen myself as well. Thank you, Mona, for the words. And let's start.
Let's start. Thank you. Good morning, everyone. I'm Tatiana, and I'm going to start sharing the presentation. Maria is going to start presentation, and then I present with her. So let's share here.
As Tatiana is a physical therapist and I am an occupational therapist, we decided to make this presentation together to be a concrete example of how we can work as a team. And our grand point will be as to use ICF as a tool to make the assessment and the therapeutic plan for our patients. And so today we will be present a theoretical basis to use ICF in physical and occupational therapy. As example, we will present some cases. The second one, please, Tatiana. And so ICF, I'm not sure how familiar all of you are with international classification of functionality, but it's a new, not a new anymore, but it's a paradigm to be used on health and has functionality as a center. Go ahead, Tatiana. And what we will cover today in our presentation, we will try to integrate the ICF classification into the clinical reasoning process of occupational therapy and physical therapy. And we will try to explain how can we use it on patient assessment and evaluation and instruments to help us to decide what we will to do with our clients, of course, having them as a center and leaders on this rehabilitation process. And then we will present to you 3 clinical case studies. The next one, please, Tatiana. And so what is ICF? ICF means that we moved from the biomedical model to the biopsychosocial model. And so the biomedical model, the focus was on disease and diagnosis, body viewed as a machine, disability as a direct consequence of pathology, professional-centered approach, isolated treatment of symptoms. And what ICF brings to us? Focus on functionality and participation and inclusion. And it's all linked with our previous presentation. Person situated with life context, disability as an interaction between health condition and environment, person-centered approach, integration of biological, psychological, and social facts. And for me, it has been used not only for this, but as a tool to create common language among all professionals who are working with the client, and not only in one country. Using this framework, we can discuss and exchange information with professionals all over the world. Next one, Tatiana. And ICF structure can, in the first view, can look like very complicated, but it's not. To use it, we have 4 core components. The first one is called letter B, that means body functionals, and they are the physiological and psychological functions of the body systems. S means body structures, anatomical parts of the body and their components. D, activities and participation, task execution and involvement in life situations. It's what the person is able or able to do in the daily life. And E, environmental factors, the physical, social, and attitudinal environment that impacts functioning. Also, in short, what it means, we understand how the body is working, how the structures of this body is working, and how all that is making the person develop or perform the activities during the life, and what are the environmental factors influencing or affecting this performance. Please, the next, Tatiana. And so for us, what's most important is to understand this gap between capacity versus performance. One thing is what the person is supposed to do, and the other one is what is really doing. And so capacity is the person can do in a standardized controlled environment, like in the rehabilitation clinic, without real-world environmental influence. Reflects maximum possible functional level, assessed in a clinical or laboratory context. Performance is what is really happening with this person in the real life, what the person actually does in the habitual living environment, including all contextual influences, physical, social, and attitudinal, reflects authentic daily functionality. And between us, that's what's really is relevant. It's how all the rehabilitation interventions can improve the performance in the real world of the person. The capacity performance gap reveals environmental impact and it's central to occupational therapy and physical therapy treatment planning. A wide gap signals that environmental barriers, not intrinsic impairment, are the primary driver of disability. Go ahead, Tatiana, please. And one of goals here today is to show through the case that we will present how these things works. As I said before, ICF can be considered the universal language of the interprofessional care, not only for the rehabilitation professional, but for the all health and social professionals who works with this client, with these same patients or clients. The next, please. And so here, what is the practical application of as ICF in occupational therapy? The ICF functions as a dynamical clinical reasoning guide, not merely as a classification instrument. It structures the entire therapeutic process for initial intake through discharge and outcome monitoring. Also, the initial assessment after we make the traditional and occupational therapy to assessment, after we collect all the data that usually we collect, we make our ICF a classification, use the codes, systematically mapping the impairments, activities limitation, participation restrictions, and environmental barriers, and facilitators for the first clinical encounter. Then we use all this information to plan our objectives and intervention planning. And you will use the same methodology to measure the outcomes and to document all the intervention process. Please, the next, Tatiana. And here we will start with some of our cases. And Mr. Joaquin, he is 68 years old, and he had a ischemic stroke. ICD was I63.9, unspecific cerebral infarction, ischemic stroke 4 months prior, right hemiplegia, mild express aphasia, privilege independent in LADLs, and active in community participation. And here you can see through this classification how we classify their impairments from body functions to environmental factors. In the end, what we see, severe capacitive performance gap in upper limb use and household tasks so identified as priority interventions. Go ahead, Tatiana.
Yes. For body functions, so he has a severe muscle strain in right upper limb, mental functions and language, mild, severe, and structural right shoulder region, also impairments. For activity and participation, hand and arm use are severe, household tasks moderate, and family relationships mild. Environment factors, it may mediate family as a facilitator, and architectural barriers stairs are very difficult for him. So he has a severe capacity performance gap in upper limb, right upper limb, and household tasks identifies priority intervention domains. Well, Mr. Joaquin, what are his clinical objectives and interventional plans? For physiotherapy objectives, we need to train gait with cane or crutch for improved ambulation, balance training on unstable surfaces and aquatic physical therapy, tone management with triple flexion exercise, stretching, and also aquatic therapy, and for proprioception and foot sensitivity, texture stimulation technique.
And for occupational therapy objectives, before I explain to them, I must remind all of us that always we must see our intervention plans linked to the national policies and regulations. And here I'm using the Brazilian regulations just to make us to understand that. And so what will be our goals? First, ADL training with adaptive techniques and assistive technology. And it is from our national law for the rights of people with disabilities a right. What means all Brazilian citizens has to have access to assistive technology. The second goal, home modification. We have ramps, grab bars, and so on. And the same legislation in Brazil assure a provision of these modifications for our Brazilian citizens. A third one, functional mobility training and return to leisure activities, caregiver education and training, coordination with physical therapy for extreme gains. The next one, Tatiana.
Well, so, Mr. Joaquin, our interventional justification. For occupational performance focus, the capacity performance gap between B7 730.3, that is severe muscle strain impairment, and D44.5.3, severe limitation in hand and arm use guide training in real-world ADL context, not isolated extreme exercise. The goal is meaningful functional performance. For environment modification, so we need we have architectural barriers that justify home adaptation, removal of stairs, installation of ramps, and grab bars as a priority occupational therapy intervention under the LDI, there is the law. Support network integration. So a facilitator indicates that the immediate family is a significant therapeutic resource. Family inclusion is the plan, ensures generalization and compensatory strategies beyond the clinical settings and support caregiver competence. The second case is Miss Fatima, 45 years old, with rheumatoid arthritis. Rheumatoid arthritis is an 8-year diagnosis, bilateral hand, wrist, and hand and wrist involvement, severe fatigue, chronic pain, work as symptoms from home, significant impact on occupational identity and economic participation. So, body functions and structures. For her, a pain severe sensation. Exercise tolerance for fatigue is moderate, and upper limb structure also moderate. For environmental factors, a personal that use products and health services as a facilitator. Activities and participation. Fine hand use for sewing, now severe. Household tasks moderate, and pain work is severe. Also, that is a very huge problem for her. So, severe impairment in paid work threatens occupational identity and economic independence, a critical interventional target.
And so for her, our goals are first, joint protection and energy conservation training. And for that, we can build or we can make some ortheses to better position these joints. As I said, wood is our second goal, hand orthosis fabrication and prescription. Third one, adaptation of household utensils and environmental reorganization. Encouragement of social participation, community groups, guidance on assistive technology rights in the public health system. And you can see our goals, all of them are based on our ICF classification. Your time, Tatiana.
Our physical therapy objectives. So, first of all, pain reduction with ice, heat, or therapeutic ultrasound, joint mobility to improve range of motion with exercises and stretching, muscle strengthening with TheraBand and PowerWeb resistance protocols and exercises, function preservation through activity adaptation, and quality of life improvement by pain reduction and maintained social participation.
It's here our justification for our intervention. First, joint protection and energy management. Our qualifiers for ICF, B280.3, the 3 means severe. So in the B2810 means pain, and B455.2 means fatigue, and moderate is the number 2. Justified structural guidance on joint protection techniques. Go back.
Sorry.
No problem. And activity organization throughout the day to manage fatigue and preserve hand functionality over time. Assistive technology and adaptations. The code from our classification use ICF E115.3 identifies the complete absence of adaptive products as a barrier. This justifies prescription of ergonomic scissors, built-up grips, and sewing supports to enable continuation of the sewing activity and preserve the worker occupational role. Occupational identity preservation. Severe impairment in D850.3, paid work, threatens Mrs. Fatima's identity as a worker, central to her self-concept and economic independence. Intervention must prioritize maintaining this occupational role, not only reducing impairment metrics. What we want from you all is to understand through cases how occupational therapy and physical therapy work together, because a lot of clients of us, not only in Brazil, but all over the world, most of the time, they don't understand how the roles of OT and PT are essential to be in a complete way to overcome all the functional limitations of our clients. And here we are showing to you guys using a universal language, that means ICF, to try to make all of us working in the same path. Go ahead, Tatiana.
So the third case study is Andrea. Andrea is watching us in this moment. She is the actual director president for the G14 Association for Polio Syndrome. She's my patient for more than 20 years, and I'm going to describe her case because it's very important, and she's a huge woman, a strong woman that I'm very happy to describe her case. Now, Andrea is 58 years old, post-polio syndrome patient, so ICD G14, more than 15 years diagnosis, bilateral lower limb involvement, a severe fatigue, progressive muscle weakness, and functional loss. She's a former accountant, worked with 10 years ago due to mobility difficulty and fatigue. For body functions and structures, Andrea feels a pain sensation severe. Exercise tolerance fatigue moderate. For muscle strength functions severe. For muscle endurance dysfunctions severe. Gait pattern functions complete impairment and lower limb structures severe. For activities, participation, and environment, a household tax moderate and strong family support, a significant facilitator. Her husband is a very friend person and helps her a lot. So she's a complete gait impairment combined with severe muscle strength and endurance deficit creates a compounding barrier to social participation and communicate integration. For
And now,
please,
so
Maria.
go ahead, Tatiana. Okay. And so what are our goals with her? First, joint protection and energy conservation training, the reorganization of daily activities to manage fatigue across the day, assistive technology prescription for mobility and home independence, social integration strategies, and quality of life improvement. And for her, this is essential. Occupational role restoration, reconnecting with productive activities.
Perfect. And for physiotherapy objectives, a neurological and aquatic physiotherapy for lower limb function. Functional model rehabilitation targeting muscle strength and endurance. Fatigue management through carefully calibrated progressive training. Gait patterns involvement and mobility enhancement, and a multimodal pain management strategy. So our intervention justification are joint protection and management qualifies and justifies structured guidance and on joint protection techniques and a systematic activity reorganization, ensuring that daily energy expenditure is balanced to prevent symptom exacerbations while maintaining functional engagement. Second, neurological and aquatic rehabilitation. These codes indicate the need for intensive functional motor rehabilitation. The therapeutic pool environment reduces gravitation load, enabling progressive strengthening and endurance work that land-based therapy alone cannot safely provide. And third, socialization and quality of life restoration. Progressive function loss and has resulted in social isolation driven by urban mobility barriers, transportation challenges, and occupational abandonment. Rehabilitation must restore occupational utility and social participation, not merely address physical impairment metrics. So, conclusion.
Go
Maria?
ahead. Okay. I hope with these cases, we can conclude, and we hope all are with together. If not, please send us questions that will be a pleasure to go deeper in what we are presenting here. So we consider ICF as the foundation of person-centered rehabilitation, not only for physical and occupational therapy, but for the whole process. And so we hope that across these three cases that we present to all, we could show you ICF not only as a classification instrument, but as an active clinical reasoning framework, guiding assessment, intervention planning, interprofessional collaboration, and outcome evaluation. And so, generally speaking, we use it as a comprehensive assessment framework, a capacity performance gap analysis, interprofessional coordination, and occupational identity and participation. Next one, Tatiana. I don't know if you want to add some words, feel free. Your mic is closed.
Okay, now. No, it's okay. I think we could describe all this for focus that are the assessment comprehensive framework, the capacity performance, interprofessional coordination, and occupational identity for important uh, phases of the rehabilitation. And I think it's important to read the, the, the last line, that is, environmental modification and assistive technology are essential rights-based components of rehabilitation, mandated by NPI and CRPD, and justified through ICS environmental factor coding. In most moments of the rehabilitation, we think that only treat the person. Pain, fatigue, weakness are the only thing we can do. But no, environmental modification and assistive technology are essential. And that's why physical therapy and occupational therapy can always work together. It's good for the patient, for family, and I say many professionals can learn a lot with this partnership. Occupational therapy and physical therapy together can do a lot for family and patients. And
Here
so
we are. Yes. Thank you to
here
all.
we
Thank you,
are.
Tatiana.
Thank you, Dr. Maria. It was a wonderful work together to show them how we can work together. Now we welcome questions, collaboration, inquiries, and further discussion on ICF application and in the professional practice. So our contacts, Dr. Maria, occupational therapy, and me, physical therapy. And we thank you very much, all of you. And now with you, Mona, please.
And I want to say thank you to both of you for telling us about your innovative procedures and helping people recover from so many varied difficulties, especially post-polio syndrome. Thank you very, very much. As we said, I'm Mona Arsenault from Canada. I'm the president and founder of Polio Quebec Association, and that includes worldwide polio support chat groups. A little more about me. I'm president of the Learning Exchange, my favorite activity, adult literacy tutor. I am proud to have been appointed as a member to the most innovative Accessibility Standards Canada, now in process for over 5 years to develop accessibility across the country. My part is Emergency Egress Priority, Positioning and Emergency Measures Act. The adult literacy community, they accept me, and I accept them. They have seen past my disability and chose to see what I can do. We are all interdependent. When you want a drink, do you grow your own coffee? My polio story is so similar to many of you who had polio that every time I hear a story, I want to shout, "Me too, me too." Along the way, I was stricken with post-polio syndrome at a time when nothing was known about this unusual difficulty. I'd like to say a few words about myself. I contracted polio in my lower limbs in 1952 at 14 months old. I had many medical operations and different forms of bracing for the first 14 years. Then went on to forearm crutches only. I led a very active adult life, had a loving, able-bodied husband for over 57 years, and raised 2 healthy sons. Suddenly, in 1984, I got post-polio syndrome. No one knew what that was, and still, we're not sure. My physical therapy experience. My shoulder replacement surgery was called a hemiarthroplasty. I had a team of professionals, anesthesiologist who listened to me, surgeon, occupational therapist, physiotherapist, and trained orthopedic orderlies. An operation on any part of you is an assault. It doesn't matter what they do to you, it's still an assault. I finally decided after nearly 10 years of excruciating pain, I had to stop using my left shoulder. It took 5 more years to find the right doctor to have this operation. Now in retrospect, I realized it was quite an ordeal. I had no idea how difficult it was going to be. So that's what I wanted to talk to you about. There are things we need to realize before having major surgery. Ask lots of questions and wait for the answers. I said to the anesthesiologist, well, it's really hard for me to have been given ether as a child. I remember the past so vividly, and especially now, right here, how those difficult memories have come back to life. Dr. Aaron said, you won't be sleeping. I'm going to try something new. It's like an epidural that we give to pregnant women during delivery. But this time, it's up in your neck instead of on the back. It worked very well. The physiotherapy and occupational therapy were tailor-made for me. It's all about how I will be able to get my body back and how I will be able to get back to what it was before the operation, before the pain of the shoulder. And like all polio survivors, we do know and can rely on our special ways to tell professionals how to move our bodies. For a shoulder operation replacement, make sure you have a proper brace to wear during the 5 weeks. Try it on before. See if it can be done up easily. How it feels. Will it work? 5 weeks are a long time to wear an uncomfortable device. Seeing as the rest of my body was weak, I had to be very careful about standing. I only did it with the help of a nurse or a physio, otherwise I was in bed. That's the reason you need to move around within the realm of not moving that shoulder at all. I was amazed at how stiff my hand became when the brace was removed. At first, only occasionally by the physiotherapist. So I kept practicing squeezing that tiny soft ball so I could do it inside the brace. Through rehab with occupational therapy and physiotherapy, I want to share with my polio friends how I feel now that I am pushed with fitting OT and PT into my everyday life. You most likely can relate to these experiences. Many of you have tailored OT and PT at various times in your life. During the first 5 weeks with no shoulder movement, it is important to move those other parts of your body so we don't atrophy or lose any muscle strength in the body. Physio was very helpful in showing me how to move properly. After the 5 weeks, I was able to do shoulder arm exercises, first without pressure and then at minimal pressure. We judge the pain threshold. If there is discomfort, stop. Rest a few moments, then continue. Do the exercises with slow, direct movements. Exhale slowly on the return positions. This eases the discomfort. I didn't know that before. Exercises should have minimal discomfort for about 10 minutes or less after the routine. If you have pain after, rest completely, ice down, do whatever it takes. Then cut back the next day. More movements only after success. Building up very slowly equals successful rehabilitation. One small movement each day. Every movement is really tough to do. Just slow down and not go any further. After 6 months, the feeling of clicking the abductors is still there. When I exceed 90 degrees, I continue the range of motion exercises and swim once a week. By being gentle with my repaired shoulder and finding out it has been successful, I can truly see how much it has improved. I will be much more prepared for the other shoulder, and I hope that you all will be much more prepared to have any type of surgery. Hopefully, it will only be elective and not accidental. One more note, be very careful to avoid bed sores. I got one and then needed expert care. It took over 3.5 weeks to fix it, but I fixed it. Thank you very much. Questions?
Thank you very much, Mona. It was history and many surgeries, rehabilitation, occupational therapy, physical therapy, treatment for pain, for function, and all of this is a story of a polio patient. And we, for health professionals, are here to work with you in all of these phases. Because in the polio sequelae, there's one reality, and the other symptoms are coming, and shoulder problems, back problems, and all of this come with aging, and we need to work together till this time. As I said in our presentation, I met Andrea more than 20 years ago. Well, she was under 40 years old, but a woman who worked as a accountability and, well, very functional person. And when the symptoms started to appearing, she was losing functionality. And we continue work together for her to have a better quality of life without pain and a function that can help her to work and to make things for ADL every day. So thank you very much, Mona. It was great to hear you.
There are some questions here. If for you, Tatiana, and Dr. Mello, how prepared is the Brazilian healthcare system to deal with long-term complications of COVID, mental and otherwise? What about the private sector?
Well, the health system in Brazil for after the pandemic was in the beginning was not good, but now I think the health management in Brazil are better, much better. We are now Brazil is looking for a better system for mental health and physical health. The hospitals are better planned, and I think Brazil is better than was, and I'm grateful for this. Brazil is better.
Very good. I'm also very proud of our Canadian government trying to put together an accessibility commission, making sure that all the needs of all the people are being met. It's a long-term job. I never thought it would take 5 years to work on emergency egress, which is the subject that I specialized in. I mean, we don't even know how to get out of a building. So this is what the government needs to do in all governments. We heard that yesterday. There's another question here. Thank you for sharing your story, Mona. I've always appreciated your contributions to the Bay Area post-polio group. It's not a question, but thank you very, very much. I have a question for both panelists, Tatiana and Maria. Are there estimates for disabilities in Brazil, and what proportion of disabilities affect the rural communities?
I will take this one. Yes, we take people with disabilities very seriously in Brazil. From our last census, we have around 10 to 12% of people with disabilities around the country. But as all you know, our country is very large, and we deal with a lot of disparities, diversity in our country. For example, at Northeast, the prevalence of disabilities is much higher than in Southeast. And other things are so different, like the resources, the clinicals, the rehabilitation centers as one. However, from 2012, Brazilian government started a very big plan to improve the health of persons with disabilities in Brazil. And they built a lot of orthopedic shops and rehabilitation centers all around the country. It's enough? Not, absolutely not yet. But we are going. And why is happening? Mainly because people with disability in Brazil are very political engaged, and we fight for our rights. And as we health professionals from the rehabilitation field, we fight together to improve and to increase the rights of access in the health system, public and private health system in Brazil. I'm sorry, and the last question about the rural communities. One thing that after 2012 improved was the access for people with disabilities living in rural areas. Why? Because they built much more rehabilitation centers around the country. And now there is a kind of transportation from rural areas to these centers. And so free transportation is provided to the government, by the government, to these people who need to go to the centers. It's enough? Absolutely not yet. We have some areas in Brazil that people are not having access to these services yet, but we believe we will improve a lot in the next 20, 30 years.
Thank you. Thank you very much. We need to hear things like that. I have another question. Is it advisable for patients with rheumatoid arthritis to undergo surgery, or is physiotherapy adequate enough? Who would like to take that one?
I can start and Tatiana can complete. Mona, depends on the case. Really, it's necessary an individual assessment of each case, because not only the biomechanics aspect that we have to consider, it's the whole system of the health of this person. And so I prefer do not say one thing is better than the other, because it's a really necessary individual and profound and holistic assessment of the situation. And you, Tatiana?
I agree. I agree with you. Each case has one kind of treatment. Sometimes surgery is necessary, but sometimes it's not. A physiotherapy or an occupational therapy, more than physiotherapy, can help the patient a lot. But individual evaluation is very important in this case.
We're getting a lot of questions now. There will be a recording, and it will be presented out to all those that have registered.
Mona, and if we don't have the time to answer all the questions, you can send a question to us and we write, and then we send back to people who made the question for us.
Yes. Yes.
Yes. We still have more time here. Is there anything else either of you would like to add to this panel?
I would like to say some more words. Tatiana and I, we already are old persons. I am older than her, but we have dealt with a lot of patients in our professional life. And for us, what we have seen, and that's why we decided to make this kind of presentation. We discussed a lot what to present. And what's the most important point here? Work as a team and consider the patient and their family as part of this team. We cannot have success if we don't consider the patient and the caregivers dynamics in the process. What works for one technique, which can work for one patient with the same disease, that will not have the same ICF code. And this is a very important point. Disease or diagnosis are not determinant of functional or functionality. And that's why ICF is so important, and to consider the client and their families as a center of this process, and call therapists with us. Please, I would love if everyone understood that and not only accept the determinations from the physicians or from the therapists. Everybody must be very active in the process of rehabilitation.
The diagnosis is not determinant for life. A classification, an evaluation, and a multidisciplinary treatment helps a lot. Each kind of patient and each type of disease. It's not our team main team here, but I work with ALS patients, and for them, diagnosis sometimes destroy a family. But no, we have a multidisciplinary team, researchers being done every year, every month, and quality of life has always to be considered for patients, for families, work with uh, adaptation in houses, and work with uh, the family and patients being well cared. So is our point of view. Me and Maria, we talked a lot about this program together, multidisciplinary team together, physiotherapy and occupational therapy together, working for quality of life, function, and activities for all of patients we can help and work. Thank you very much.
I have one more statement here, and I think it's very valid, from Gladys. Thank you so much for this session. I am glad to be part of this from Kenya. I am a sign language interpreter and also passionate on matters of disability. I work in the Department of Persons with Disabilities. There is need for more advocacy for polio as a disability in Kenya. I will be glad to partner with this amazing team to make this possible. Thank you. And I would
You're
say
welcome.
Welcome.
welcome. Yes, and please contact me. The one thing I want to say to all people is that if you can join a chat group for support, this is the most amazing thing people with polio can have. And I am open to all people who would like to chat. There are chat groups all over the world, and please contact a group.
Yes,
Yes.
and Mona,
Stella, I am a Rotarian and a health educator and would like to include disability in our palliative care training.
great.
I have another question. My name is Gritty, a Mandela Washington Fellow, public health nurse, and a disability and social advocate in Guyana, and a sign language interpreter. I have been in the community for the past 13 years in this field. I became an advocate because my sister became deaf because of measles. Please, I want to know if there is a special course, a professional that I can pursue. All these years of my practice, I do not have any courses in disability, but I train, facilitate my staff in the field to practice disability-friendly faculties. Training is what we all need.
Yes, absolutely. Yes, in Brazil, we have a lot of postgraduate courses, trainings, and I believe in Europe we can access as well. Mona, maybe if you can get the contact of this person, I can try to find some trainings specifically in a way that could match her needs. I'm please, if you can get her contact, and then later we can send her some information.
Yes, please send your email to me. My email is open, and I don't know exactly how to do this. Ken will have my email address.
Oh no, this
Right.
is Ken. This is Ken Masson. They can also write to Rotary WDA@gmail.com, and we'll get them in touch. We'll get back to them. Okay.
Again, I want to say thank you, Tatiana and Maria, for a wonderful, wonderful presentation. It has been sorely needed, and knowing that there are people who can get help.
Thank you
It
very
was a
much,
pleasure.
Mona. It was a pleasure, Ken. Thank you very much, Dr. Marta. Thank you very much, Sonia, and all of you were incredible. You were wonderful. Thank you again.
Yes, and I'd like to say thank you and publicly congratulate Dr. Marta to organize this wonderful summit. It will be the first of many other events which will change the lives of a lot of people around the world. It is a pleasure to be here with all today. Thank you very much.
Thank you, thank you, thank you. That was a wonderful presentation, ladies. Well done. You have taken the bar so much higher with your presentation, so we are so thankful to you. Clearly, what we were seeing in the background was that we had patients who were seeking answers, and this presentation has definitely answered most of their questions and has given them hope, which is what advocacy is all about. For those of you who may not be very well versed with what this particular presentation was all about, in simple terms, the ICF helps us understand how physiotherapists and occupational therapists have different but equally important roles in helping people live better lives. Physiotherapists help people improve their movement and physical strength, while occupational therapists help them manage everyday activities as independently as possible. So, what were their case studies showing us? Their case studies and presentation was showing us that together they work as a team to provide well-rounded care that meets each person's unique needs. Remember, they both insisted each patient's needs are different, even if the diagnosis may be the same. And it helps the patient participate fully in daily life. So if you remember from our presentation of yesterday, we were talking about the small wins. The small wins, we must celebrate the small wins because they may look small to one person, but for the one who's going through them, those are big wins every single day. So don't give up. Thank you once again, ladies. You were awesome.